A very good day to Doctor. So in our presentation today, my group will be talking about the drug treatment options for thyroid disorders. My name is Chang Fang Yi, so I'll be starting the presentation for my group and I'll be talking about the drug treatment options for hypothyroidism. So for hypothyroidism, there is two types of drugs that we can give to the patient. First one is the natural thyroid hormone and the second one is the synthetic hormones. So for the natural thyroid hormone, it is actually obtained from the dry thyroid of mammals, for example, the cow and the pig. So the thyroid of these animals, they are being dried and then take out all the fat and then grind into powder form so that the patients can take it in tablets form through the oral pathway. And we give the natural thyroid hormone when the patient has an allergic reaction to the synthetic hormones drug, which I'll be talking about later. So for the mechanism of action for natural thyroid hormone, it is actually similar to the thyroid hormones that is in our body because it will just replace the endogenous thyroid hormone production in our body, therefore increases the uh, level of thyroid hormone in our body, and then it will help with the condition of hypothyroidism. For the natural thyroid hormone, the dosing precision is not possible. That's why it is not recommended to use natural thyroid hormone in patients with hypothyroidism. And if you are using it, we normally start with a low dose with increment of the dosage depending on the cardiovascular status of the patient. So, for example, if the patient has any cardiac diseases, we will actually need to even lower the dosage. And the usual starting dose is 32.5 milligram with an increment of 16.25 milligram every 2 to 3 weeks. And this is the dosage regimen usually for adults. For the pharmacokinetic for the natural thyroid hormone, it is actually same with our thyroid hormone that is synthesized in our body naturally. So it will bound to serum proteins, for example, like the thyroid binding globulin, TBG, thyroid binding prealbumin, or the albumin. The adverse effect of natural thyroid hormone includes chest pain, increased pulse rate, palpitations, excessive sweating, heat intolerance, nervousness, and hair loss. So you can actually see that the adverse effect for natural thyroid hormone is similar to the symptoms of hyperthyroidism. The next group of drug that can be given to the patient with hypothyroidism is the synthetic hormones. So the first type of synthetic hormones is the levothyroxine. We give levothyroxine to all forms of hypothyroidism condition present in patients and also as thyroid replacement in patients undergoing treatment of thyroid cancer or hyperthyroidism. So like patients with hypothyroidism might be undergoing radioactive iodine therapy, right? So we will actually give the levothyroxine to replace or no to avoid hypothyroidism to happen in that patient undergoing the radioactive iodine therapy. So the mechanism of action for levothyroxine is the same with the thyroxine hormones that is synthesized in our body because it is a synthetic form of the thyroxine T4 hormones. And the starting dosage for levothyroxine are usually the same for adult, which is 50 microgram to 100 microgram once a day. But the dosage actually varies also. It depends on how quickly the dosage is increased, the patient's symptoms, hormone levels, age, and also any other health problems. And for levothyroxine, it is mainly absorbed in small intestines and it is majority of the levothyroxine will be metabolized by the deiodination reaction, which is a reaction where the iodine is removed from the levothyroxine. And it is also highly bound to plasma proteins, predominantly the thyroid binding globulin. And if you have an overdose of levothyroxine, you will get the effect of hyperthyroidism. So for example, like excessive sweating, anxiety, increased heart rate, all these symptoms of hyperthyroidism. And if you have an acute overdose of levothyroxine, you are at risk of getting angina pectoris, cardiac arrhythmias, or even cardiac failure. So it is symptoms that is associated with your cardiovascular system. And if you're using levothyroxine for long term, it can actually increase the bone resorption. Therefore, it will lead to osteoporosis. And if you are taking excessive levothyroxine, too much of the levothyroxine, you will actually be at risk of thyrotoxicosis factitia, which can also lead to the thyroid storm, and it is a clinical emergency. So the next type of synthetic hormones is liothyronine. It is the most potent form of thyroid hormone the out of all the hormones that I have, out of all the drugs that I have talked about. So we use liothyronine along with levothyroxine in situation where the levothyroxine alone does not provide relief of symptoms to the patient with hypothyroidism. And liothyronine is actually a synthetic form of the thyroid hormone T3 in our body. So the mechanism of action is the same with the thyroid hormone T3 that is synthesized in our body. And the starting dose is 25 micrograms once a day for adults, and it might be adjusted as needed. And if you actually compare with the levothyroxine T4, liothyronine has a faster onset of action. And this is due to the liothyronine has lesser plasma protein binding compared to the levothyroxine. The adverse effect of liothyronine is actually similar to levothyroxine, but more severe or life-threatening. So the treatment of choice, I would say the treatment of choice, if you look at these three types of drugs that I've talked about, the treatment of choice will be the levothyroxine because it has less, the adverse effect of the levothyroxine is actually less severe compared to liothyronine, and we can actually uh, control the dosage if you compare it to natural thyroid hormone where the dosing precision is not possible. So this is all for my part. I will pass it to the next person. Thank you.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. My name is Siti Fatimah binti Othman. My metric number 200696. Okay, insyaAllah. First of all, before I start, I'm sorry because I can't open my camera because I have problem with my camera. Okay, for today, for my part, I will explain for the drug treatment option for hyperthyroidism. The first one, anti-thyroid drug therapy, ATDs. The first one is propylthiouracil (PTU) for indication for this drug. Thyrotoxicosis, which is the thyroid storm. High dose must be used to treat thyroid storm. Okay, this PTU is favored over the metimazole for this indication because of its effect to block T4 to T3 conversion. Okay, for the mechanism of action for this drug, it's prevent the thyroid hormone synthesis by inhibiting the thyroid peroxidase catalyst reactions and blocking iodine organification, the major mechanism of action. And this drug also it's block coupling of iodotyrosine and also is inhibit the peripheral deiodination of T4 to T3. Okay. For the dosage regimen for this PTU is usually begin with divide doses, shifting to maintenance therapy with single daily doses when the patient become clinically euthyroid. Okay. However, mild to moderately severe thyrotoxicosis can often be controlled with metimazole given in a single morning dose of 20 to 40 milligram initially for 4 to 8 weeks to normalize hormone level. Okay, it's also the maintenance therapy required 5 to maintain this therapy is required 5 to 50 milligram once daily. So for the dosage regimen also, alternatively, therapy is start with propylthiouracil, thiouracil 100 to 150 milligram every 6 or 8 hours until the patient is euthyroid, followed by gradual reduction of the dose of the maintenance level of 50 to 150 milligram once. Okay. Next, for the pharmacokinetic for this drug PTU, since synthesis rather than release of thyroid hormone is affected, there is a slow onset of observable effects, often taking 3 to 4 weeks before stores of T4 are depleted. Before the adverse effect for this drug, for this PTU, it can cause the rush, which is the common one will happen. There is also can cause edema, granulocytosis, which is the rare happen in average of 0.1 to 0.5%, and this is usually reversible upon the drug when the drug is withdrawal. Okay, this for the adverse effect for the PTE also it can cause hepatitis. It's also rare, but if this hepatitis happen, it can potentially fatal. Last one for the adverse effect is can cause the cholestatic jaundice, rare but potentially fatal and more common with methimazole. Okay, the next drug, the number 2 in the same and also in the same category ATD is the methimazole. Okay, for this indication for the methimazole is treatment of hyperthyroidism. Um, in non-adult, methimazole is the primary drug used to treat grave hyperthyroidism. Compared to PTU, methimazole has a longer duration of action and more rapidly result in euthyroid state. For normally T4 and T3 level after onset of therapy. Okay, next is for the indication for this drug, methimazole, is to reduce the degree of hyperthyroidism in preparation for subtotal thyroidectomy or radioactive iodine therapy. Used when thyroidectomy is contraindicated or is not advisable. Okay, for the mechanism of action for this drug, methimazole, is more than 10, almost 10 times more potent than PTU. It prevent the thyroid hormone synthesis by inhibiting the thyroid peroxidase catalyst reactions and blocking iodine organification. The major, which is the major which is the major mechanism of action. Its mechanism of action on the thyroid gland is the same as PTU. However, methimazole does not effectively block peripheral deiodinase, the one that convert T4 to T3. We can see for the PTU, it inhibit the peripheral deiodination of T4 to 3 to T4 to T3. Okay. For the dosage regimen, it same like as PTU. It same goes with the pharmacokinetic. Okay. For the adverse effect for the methimazole, it can cause the maculopapular rash, or around 4 to 6% of patient, and the most common side effect sometimes associated with fever. Next, agranulocytosis, which is this dangerous but very rare. Next is hepatitis, is more common with PTU. Cholestatic jaundice has been reported and can be fatal. It's actually it's same. It's almost same lah. Like the adverse effect for the PTU. For this adverse effect for the methimazole, it also can cause nausea, GI distress, ulcer taste, or smell. Okay. Okay, sorry. Okay, next. also in the same category, is the radioactive iodine 131. Okay, for the indication for this drug, radioactive iodine uptake test to evaluate thyroid function. For the thyrotoxicosis, multinodular hyperthyroidism, and toxic adenomas, it's also used for the advanced patient age. What I read is used with the patient if above than 21-year-old. Significant comorbidity, prior surgery or scarring in the arterial neck, small goiter size, RAIU, um, sufficient to allow therapy. Also lack of access to a high volume thyroid surgeon. Okay, for the mechanism of action for this radioactive iodine, um, iodine 131 is rapidly absorbed and is concentrated in the thyroid where it is incorporated into storage follicle. Okay, this also is therapeutic effect depends on emission of beta rays with an effective half-life of 56 days. This beta particle act on parenchymal cell with little damage to surrounding tissues. Okay, for the dosage regimen for this drug, in patient without heart disease, the therapeutic dose may be given immediately in a range of 80 to 120 micro CI per gram of estimate thyroid weight corrected for uptake. Okay, for the adverse effect for this radioactive iodine 131, it can cause a delay hypothyroidism. Okay, the next category is the beta blockers. Okay, indication for this beta blockers is prompt control of symptoms, treatment of choice for thyroiditis, first line therapy before surgery, radioactive iodine, and anti-thyroid drug. Okay, this also can short-term therapy in pregnancy. For the mechanism of action for the beta blockers, it will inhibit the adrenergic effects. For the beta blockers, there are two that I found. The first one is atenolol. Atenolol is for the dosage regimen. 20. We will give the patient in 25 to 100 milligram orally once per day. For the pharmacokinetic for this atenolol is selective beta blockers, safer than propranolol in asthma or chronic obstructive pulmonary disease. Once daily dosing improve compliance. For the adverse effect for the atenolol, it can cause the exacerbation of congestive heart failure. Okay, the last one is propranolol. For propranolol, for the dosage regimen is immediate release. For the immediate release, we give patient 10 to 40 milligram orally every 8 hours. And for the extended release, we will give 80 to 160 milligram orally once per day. Propranolol can decrease the T4 to T3 conversion. This propranolol is also one of the non-selective beta blockers. For the adverse effect for the propranolol, it's also same like atenolol. It also can cause the exacerbation of congestive heart failure or asthma. Okay, I think that's all from me. Okay, thank you.
So I will continue with thyroid nodules or goiter treatment. So first, goiter is a discrete lesion within the thyroid gland that is due to an abnormal focal growth of thyroid cells. So in the treatment, we will cover three, which first is the thyroid hormone suppression therapy for patients with goiter presented with hypothyroidism. And second is for thyroid hormone suppression therapy for patients with goiter presented with hyperthyroidism. And lastly, for the treatments of goiter is radioiodine therapy. Okay, for first treatment, which is the thyroid hormone suppression therapy for patients with goiter presented with hypothyroidism, we will give levothyroxine and liothyronine, which both are the synthetics for thyroid hormone. The mechanism of actions of this synthetic thyroid hormone will activations of nuclear receptor that can result in gene expression with RNA formation and protein synthesis. So the dosage regimen for both is 50 to 200 micrograms per day. The pharmacokinetics for levothyroxine and liothyronine, it has half-life of 7 days and it will be excreted in the urine and feces and is almost completely bound to plasma protein. And for the adverse effects for levothyroxine and liothyronine, it can cause arrhythmia, vaginal pain, tachycardia, disorders of menstruations, cramps, headache, excitability, flushing, sweating, diarrhea, excessive weight loss, muscular weakness, insomnia, tremor, fever, vomiting, heat intolerance. Second, treatments for patients with goiter presented with hypothyroidism, we will give methimazole and propylthiouracils, which will inhibit thyroid peroxidase reaction. It will block iodine organification and inhibit peripheral deiodinations of T4 and T3. And for the dosage regimen for PTU, we will give 100 milligram dose every 6 to 8 hours. For methimazole, we will give 30 milligram dose every 24 hours. Pharmacokinetics for methimazole and propylthiouracil is completely absorbed but at variable rates and it is readily accumulated by the thyroid gland and 65 to 78% of the dose will be recovered in the urine in 48 hours. And it has short plasma half-life, which for PTU, it has 1.5 hours of half-life and 6 hours for methimazole half-life. The adverse effects for methimazole and propylthiouracil will include nausea, GI distress, rash, granulocytosis, hepatitis, hypothyroidism. And for patients that is pregnant, we should not we should avoid this methimazole and propylthiouracil as it can cross placental barrier and concentrated the fetal thyroid. As in PTU, is actually preferable during first trimester only because it is strongly protein bound. And for methimazole, it has associated with congenital malformation. However, it's still rare. So we should avoid using methimazole and propylthiouracil for pregnant patients. Okay, lastly is the radioiodine therapy, which the radiation will disrupt the thyroid parenchyma that will evidenced by epithelial swelling and necrosis, follicular disruption, edema, and mucosal infiltration. The dosage regimen for radioiodine therapy is 150 to 200 microgram and will be given orally. And pharmacokinetics, effective half-life is 5 days and it will be administered orally in solution as sodium iodide and it is rapidly absorbed and concentrated by the thyroid so it can incorporate with the storage follicles. The adverse effect for radioiodine therapy include sore throat, cellulitis, and hypothyroidism. For patient that is pregnant, we should avoid using radioiodine therapy because it can cross the placenta and destroy the fetal thyroid gland. As of patient that is lactating mother, we should avoid radioiodine therapy because it can be excreted in breast milk. So these are all the treatment will be given for thyroid nodules or goiter. Thank you.
A very good day I bid to doctor and also to my fellow friends. So today now I'm going to explain about thyroid emergencies and the post-operative management associated with it. So basically these thyroid emergencies can be divided into two. One would be the thyroid storm and the other one will be myxoedema coma. And I today will explain about thyroid storm and how this thyroid storm can be managed in terms of medication. So first of all, the first primary drugs that can be given to treat this thyroid storm is propylthiouracil, which is also known as PTU. and it's normally recommended in patients with pregnant and lactating women, because normally this propylthiouracil has a very low transpassage pathway to the placenta of the fetus and also to the breast milk of the mothers as well. So this propylthiouracil's mechanism of action would be it inhibits the enzyme thioperoxidase, and we know that this enzyme thioperoxidase is very essential in order for the binding of iodine and also for the coupling of this iodotyrosine. So by inhibiting this enzyme thioperoxidase, binding of the iodine and also the coupling of iodotyrosine can be inhibited. This in turn will reduce the synthesis of thyroid hormones. And not only that, this propylthiouracil also has an additional benefit by blocking the conversion of thyroxine to triiodothyronate by inhibiting the enzyme 5-deiodinase. And what about the dosage regimen of this propylthiouracil? So propylthiouracil, first, it needs to have a loading dose, and then as a booster dose, we give a recurring dose after this loading dose has been already been administered. So for this loading dose, an amount of 500 to 1000 milligram of loading dose should be administered in the patient, and later 250 milligram of this propylthiouracil needs to be administered inside the patient every hour for 4 times. So now let's go to the pharmacokinetics of this propylthiouracil. So this propylthiouracil is administered orally, and it almost has 100% absorption. The bioavailability will be 100%, nearly complete, and the protein binding of this propylthiouracil will be 80 to 90% with a half-life of 1 to 2 hours. And the total volume of distribution required for the efficient and the most effective efficacy of this propylthiouracil would be 20 liter of distribution, and the duration of action of this propylthiouracil will be 12 hours to 24 hours, which is almost like 1 day or half a day. And this propylthiouracil will also be metabolized in the liver and kidney. So as I told before, this propylthiouracil has a low transplacental and breast milk passage, so that's why it can be recommended to pregnant and lactating women. And this propylthiouracil also undergoes glucuronidation and can be excreted in bile. So that's for the pharmacokinetics of PTU. Now, what about the adverse effects of this PTU? So normally this propylthiouracil, once administered, it can have many adverse effects like fever, maculopapular rashes, urticarial rashes, exofoliative dermatitis, which is kind of skin disease, acute arthralgia, nausea, vomiting, hepatitis, and cholestatic jaundice, which is very rare for propylthiouracil. So that's for the first explanation about the drug treatment options for thyroid storm. Now let me step into the next drug treatment for this thyroid storm. Next would be the metimazoles, MMI. So both of these propylthiouracil and metimazole belongs to the same group, which is the thiuralanes or thienamides also. So they belong to the same group. So metimazole is normally recommended for non-pregnant women. Okay, so the mechanism of action of this metimazole is same as propylthiouracil, since both of them belongs to the same group. They inhibit the enzyme thyroid peroxidase, which inhibits or reduces the synthesis of thyroid hormone. But the only difference is that metimazoles cannot block the conversion of thyroxine to triiodothyronate, like what the propylthiouracil did. That's the only difference between the mechanism of actions of propylthiouracil and metimazoles. And what about the dosage regimen of metimazoles? It's quite different from propylthiouracil. So propylthiouracil usually require 2 different kinds of dosage. One is the loading dose, and the next is a kind of a recurring dose after that. But for these metimazoles, only one type of dose can be administered, which is either if you want to give it a single dose, you have to administer an amount of 60 to 80 milligram per day. And if you think that single dose is like quite inconvenient, you can actually divide that equally to 2 doses per day, which means 30 to 40 milligram per day. So that's the dosage regimen for these metimazoles. Next, I would like to go for this pharmacokinetics of this metimazole, which is also almost same like your propylthiouracil, since, as I've already told, since they belong to the same classes of drug. It's oral, and it also almost has a nearly complete absorption, nearly 100% absorption. However, they have a negligible protein binding, which means the protein binding of this metimazole is extremely less. The half-life is almost like 4 to 6 hours, and the volume of distribution is 40 liter of distribution. And normally the duration of action is more than 1 day. And like the propylthiouracil, metamazoles are also metabolized in liver and kidney. And almost same like the propylthiouracil, these metamazoles also have a very low transplacental and breast milk passage. Even they also undergoes glucuronidation and excreted in bile. So now let's go to the adverse effect of metamazoles. So the common adverse effects is almost same like the PTU, which is the propylthiouracil, but these metamuciles have an additional or some distinctive adverse effects that cannot be seen with a propyltyrosine, and they are alteration of the sense and taste, and alteration of the sense of taste and smell of the patient, pancreatitis, and cholestatic jaundice. So these are some different kinds of adverse effects that metamuciles cause to the patients get administered with it. Now the third class of drugs that can be used in order to treat this thyroid storm is beta adrenergic receptor blocker. So this beta adrenergic receptor blocker is used not as a curative purpose for this thyroid storm, but it's a kind of a palliative method. Palliative method means it's like treats the signs and symptoms, the clinical manifestations of thyroid storm, but it can never cure the thyroid storm. So examples of beta adrenergic receptors are propranolol and bisoprolol, landiolol, and esmolol. So propranolol is normally contraindicated in patients with cardiovascular complications, congestive obstructive pulmonary disease, and also asthmatic patients. And why is that? Because propranolol is a non-selective beta blocker. They can also block all the beta 1 and beta 2 receptors that can be found in the entire body. But bisoprolol, landiolol, and esmolol, they are selective blockers. So they only block the receptors that can be found in the heart. So now the mechanism of action of beta adrenergic receptor blockers is normally these beta adrenergic receptor blockers functions as an adjunctive therapy for thyroid storm, which means they are not the primary drug that can be used to treat thyroid storm, but they can just use an adjunctive therapy as a supportive measures. Okay, so as I've already told you, it's a kind of cure, it's a kind of palliative therapy that people use this beta adrenergic receptor blocker. And why is that? Because it acts like a sympatholytic agent, which means these drugs elevate the sympathomimetic manifestations of thyroid storm, like palpitations, sinus tachycardias, atrial fibrillation, anxiety, heat tolerance, and many more. And only propranolol from this class can additionally inhibit the conversion of thyroxine to triiodothyronine in peripheral tissues. So this shows that beta adrenergic receptor blockers cannot cure the thyroid storm, but they can only remove or reduce or even like eliminate or diminish the signs and symptoms or the clinical manifestations of thyroid storm. So the dosage regimen for beta adrenergic receptor blockers is very easy, which is 60 to 80 milligram, should be administered every hour for 4 times in a day. So next, I would like to go for the it's for the adverse effect of beta adrenergic receptor blockers, which should be the fatigue and dizziness, poor circulation, gastrointestinal symptoms, and sexual dysfunction, also weight gain. So these are some of the adverse effects that can happen with beta adrenergic receptor blockers. Okay, now next I would like to go for the fourth class of drug, which is calcium channel blockers. So for these calcium channel blockers, it's recommended normally for patients with bronchial asthma and also with COPD patients. Like as I've already told you before, beta adrenergic receptor blockers are contraindicated in patients with COPD and cardiovascular complications and also asthmatic patients. So for those kinds of patients, calcium channel blockers are very much recommended. And examples of calcium channel blockers that can be used are diltiazem and intravenous esmolol with a shorter half-life. Okay, so the mechanism of action of calcium channel blocker is exactly the same like how the beta adrenergic receptor blockers. They will be used as a palliative method to reduce the signs and symptoms and the clinical manifestations of thyroid storm. And it's only recommended in patients with bronchial asthma and chronic obstructive pulmonary disease. So what about the dosage regimen of calcium channel blockers is, for example, intravenous esmolol. Just example, intravenous esmolol can be given with a loading dose of 250 to 500 mcg per kg. And for the diltiazem, sorry, I didn't write that. For the diltiazem, it's about 550 to 100 mcg per kg per minute. So this is the dosage regimen that is required to be administered in a patient's body. So now I would like to go for the for the pharmacokinetics. For the pharmacokinetics of calcium channel blockers, which is oral or IV administration, depends on the patient's convenience and also the bioavailability and also the efficacy of the drug. And the problem is calcium channel blockers have an extensive first pass effect. So that's why usually instead of choosing oral, IV administration are more preferred because it has a very extensive first pass effect that can reduce the bioavailability of the drug and which indirectly will affect the efficacy and also the therapeutic effects of the drug as well. So the bioavailability of the drug is 40% and it is metabolized in the liver. So calcium channel blockers also have certain certain serious but at the same time important adverse effects that needs to be taken into consideration, which are constipation, palpitations, flushing, headache, nausea, rashes, and also dizziness. This is because calcium channel blockers can affect on both of the vessels and also the muscles of the patient. So these are the reasons why it can have adverse effect mostly concentrated on the muscles like constipation and also the vessels like flushing and palpitations. So next, I would like to go for the last class of drug that can be administered to this patient with thyroid storm, which is Lugol's iodine. So this Lugol's iodine is a kind of inorganic iodine. You know, like in for example, this iodide kind of drugs, there are two different kinds of drugs, which is organic iodine and inorganic iodine. So this is an inorganic iodide, Lugol's iodine. So normally this is recommended in patients when other types of anti-thyroid therapy fails. Like for example, the anti-thyroid therapies that I've already enlisted just now, if all of them fails, that's when this Lugol's iodine is normally administered. So it's not the first line, it's not the first line of treatment. Okay, it's usually recommended as the last part. And as same like the beta adrenergic receptor blockers, Lugol's iodine is also an adjunctive therapy, but this time it is for thyroidectomy. If the patient is to have a thyroidectomy, they want to, I would say, they want to excise the thyroid gland because of recurrency or because of a seriousness. So this Lugol's iodine is given as an adjunctive therapy. Why? It's because it can reduce the vascularity and the fragility of the thyroid gland during the surgery. And normally this Lugol's iodine, as I told, since it's a last line of therapy, it's not routinely used in hyperthyroidism patients. How this Lugol's iodine, what are the mechanism of action of this Lugol's iodine is, it blocks the uptake and incorporation of iodine into the thyroid gland, what we call as Wolff-Chakoev effect. And not only that, it also inhibits thyroglobulin iodination in thyroid gland. So because we know that in order for thyroid hormone to be synthesized, this iodination, which means the iodide, which is already be converted into an oxidized iodine form, needs to be iodinated on the thyroglobulin complex. So if this doesn't occur, then the following processes like the coupling and the secretion will not occur as well. So now in this case, it inhibits the thyroglobulin iodination. So which in case will of course inhibit the synthesis of the thyroid gland, and it also reduces the vascularity of the thyroid and inhibit the deiodinase activity. So what happens when this deiodinase activity is inhibited? Of course, the conversion of the thyroid from the thyroxine, which is an inactive state, to triiodothyronine, which is an active metabolite, cannot occur. So this will reduce the secretion or the synthesis of thyroid hormones. Now next, it's actually the dosage regimens of this Lugol's iodine. So since Lugol's iodine is a kind of a solution, we normally use 5 drops for every 6 hours. That means every 6 hours, 5 drops of this Lugol's iodine will be taken. So 5 drops of Lugol's iodine is like equal to 6.25 milligram of iodine per drop. Or we can use 10 drops for 8 hours, which means every 8 hours, 10 drops of this Lugol's iodine is administered. And one more important thing is, this Lugol's iodine should not be given beyond 10 days, as it can escape from the Wolff-Chakoev phenomenon. The Wolff-Chakoev phenomenon, which is actually the uptake, of uptake and incorporation of this iodide into thyroid gland cannot occur. So if that doesn't occur, then the entire blockage or the entire inhibition of the thyroid synthesis hormone will not occur, and this will paradoxically increase the hormone secretion as well. So it's like a counteractive mechanism will occur. So now the Lugol's iodines, pharmacokinetics is, the Lugol's iodine it's taken orally because it's an oral solution, and it has very high drug interactions. Like it can interact with many classes of drug like ACE inhibitors, enalapril, lansoprazole, and many more, and also angiotensin receptor blockers, and also eplerenone and lithium. So there are many classes of drugs that can interact with the Lugol's iodine and can affect or alter the metabolisms of this drug as well. So now last but not the least, which is the adverse effects of Lugol's solution. So the adverse effects of Lugol's solution, as I've already told, chronic usage, which means beyond 10 days of usage, can paradoxically increase the hormone release. This is because this mechanism causes the Lugol solution to escape from Wolff-Chakoev effect. So this causes more and more of this iodide hormone to be uptaken by the cells, and the hormone synthesis will start to occur at an increased rate. Next, it will be jot-based dose effect, and the most important adverse effect is it will result a patient to have acneiform rash, which is a kind of rash, and swollen salivary glands, conjunctivitis, and a kind of infection on the eyes, rhinorrhea, which is something kind of inflammation on the nose. You can have metallic taste, bleeding disorders, and anaphylactoid reactions. So these are all the drugs that can be used for thyroid storm, that can be used for thyroid storm patients, and also with its corresponding mechanism of actions, dosage regimens, its pharmacokinetics, and also its adverse effects. So that's all from me. I would like to pass the
Very
stage to
good
my
day to
next
Doctor
friend.
and
Thank you.
friends. I'm Safia binti Muhammad Ayub. Today I'll be continuing the presentation with mixed edema coma. Firstly, let's get to know what is mixed edema coma. Mixed edema coma is a rare condition which is diagnosed clinically in patients presenting with hallmarks of reduced conscious level and hypothermia. Thyroid function tests will show consistent hypothyroidism. Other clinical features of mixed edema coma are hyponatremia or hypercapnia. So what are the best treatment for mixed edema coma? Patients who have been diagnosed with mixed edema coma are critically ill and should be nursed in intensive care wards. So the first treatment line for this mixed edema coma is intravenous hydrocortisone. Intravenous hydrocortisone should be given as an initial treatment before thyroid hormones. However, before taking intravenous hydrocortisone, serum cortisol should be taken. The dosage recommendation for intravenous hydrocortisone is 200 mg times 100 mg, 6 to 8 hourly, which should be administered prior to levothyroxine, like I have mentioned. Some of the adverse effects of intravenous hydrocortisones are headache, increased sweating, trouble sleeping, upset stomach, increased appetite, nausea, and weight gain. The next treatment, which should be given after the intravenous hydrocortisone, is intravenous levothyroxine. It is a synthetic form of tyrosine which is given intravenously. The dosage requirement is 200 to 400 mcg followed by 1.6 mcg per kilogram per day. If intravenous levothyroxine is not available, oral levothyroxine can be given as 500 mcg loading followed by maintenance dose. Some of the adverse effects are seizures, fast heartbeat, fever, itching, skin rashes, hoarseness, redness of the skin, swelling of the eyelids, face, lips, hands or feet, and also tightness in chest, and also the last one is trouble breathing or swallowing. And the final one is intravenous liothyronine. So this is only taken when available, and it is actually an additional treatment to the intravenous levothyroxine. This is a synthetic form of thyroid hormone T3, and the dosage recommendation is loading dose of 5 to 20 mcg followed by 2.5 to 10 mcg every 8 hours till patients regains the consciousness. Some of the adverse effects includes dizziness, fainting, fast, slow, or irregular heartbeat. Usually in patients of mixed edema coma, improvements can be seen within 1 week of treatment, and there will be multi-organ parameters that should be measured or monitored as well. For example, mental status, cardiovascular parameters, respiratory parameters, renal function, and metabolic parameters. Thyroid function tests can be monitored every 2 days. And that is all from me. Thank you.
A very good day. My name is Vignesh Rao, and for the next part, I will present on the management of thyroiditis, which are subacute and also acute thyroiditis. So, for subacute thyroiditis, there are actually three causes of management or drugs, which are NSAIDs, corticosteroids, and also beta blockers. So, before I proceed, what is subacute thyroiditis? Subacute thyroiditis is actually an acute inflammation of thyroid gland, which is usually caused by virus infection. So the first cause of management is non-steroidal anti-inflammatory drugs, which is NSAIDs. Actually, NSAID is the first line therapy for subacute thyroiditis, and it is normally given for patients with mild symptoms. So an example of NSAID is aspirin. So the mechanism of action of aspirin is it will irreversibly inhibit cyclooxygenase 1 and 2, which leads to decrease in prostaglandin synthesis, which leads to an anti-inflammatory effect. So the pharmacokinetic of aspirin is the absorption is rapid and complete following oral administration. And the excretion of salicylates, which is the byproduct of aspirin, is through the kidney, and the half-life normally ranges from 13 to 19 minutes. Next, the adverse effects of aspirin may include bleeding, gastritis or gastric ulcers, allergic reaction, or Ray's syndrome. Okay, the next course of management or drug for subacute thyroiditis is corticosteroids. Okay, corticosteroids are normally given for patients with severe symptoms or for those who do not respond to initial NSAID therapy. So, an example of corticosteroid is prednisolone. So, what prednisolone does is prednisolone will mimic the action of endogenous glucocorticoids. For example, vasoconstriction, induction of apoptosis of lymphocytes, and also the inhibition of prostaglandin and leukotriene formation through inhibition of phospholipase A2. So the dosing regime for prednisolone is normally we start with dose of 15 milligram per day, tapered to 5 milligram per day every 2 weeks. And the duration of prednisolone may be prolonged in cases with persistent symptoms of raised ESR or CRP levels. Next, the pharmacokinetics for prednisolone is it is usually 70% bioavailable if taken orally. And prednisolone is also over 98% eliminated through urine. Prednisolone has a plasma half-life of 2.1 to 3.5 hours. And normally the half-life is shorter in children and longer in those with liver disease. The adverse effect may include Cushing syndrome and also fat redistribution. And the last cause of drug for subacute thyroiditis is beta blockers. Actually, beta blockers are used for patients with symptoms of thyrotoxicosis. So, an example is propranolol. Propranolol is actually beta receptor will exert beta receptor blocking action and direct membrane effects. So the selectivity for this propranolol is beta 1 receptor, and it may induce prolonged cardiac action potential. So the um, dosage regime for propranolol is normally we give the lowest dose as possible to alleviate the symptoms only. Next, the pharmacokinetics is propranolol is usually completely absorbed after an oral administration. The half-life is within 3 to 6 hours, and propranolol is highly bound to plasma protein. So the adverse effects of propranolol are bradycardia, chronic heart failure, nausea, vomiting, and also hypersensitivity reaction. So that is all for subacute thyroiditis management. Next, we move on with acute or suppurative thyroiditis management. So the management for acute thyroiditis is usually a prescription of antibiotics, but in some cases, we have to perform surgical extraction of the thyroid gland. So for antibiotics, there are a few types that we can prescribe, which are penicillin, clindamycin, metronidazole, and also ampicillin. So today I'll be explaining on penicillin. So penicillin is actually an antibiotic with activity against gram-positive, some gram-negative, and some anaerobic bacteria. So penicillin will bind to peptidoglycan binding protein, which will inhibit bacterial cell wall growth. So this will exert bactericidal activity. So the dosage regime for penicillin is usually 5 to 24 million units per day intravenously, divided in 4 to 6 hours, within 4 to 6 hours. So the pharmacokinetics is it is normally rapidly absorbed following both intramuscular and subcutaneous injection. And penicillin G is usually eliminated by the kidneys. So next, the adverse effect, which includes allergic reaction and sometimes drug-induced co-oms positive hemolytic anemia. So that is all for management of thyroiditis, subacute and acute thyroiditis. Thank you very much.
Hello, I'm Rudenia Shaila, and for the part of my presentation, I will be cover for the treatment of thyroid disorders for special situation. That will include hypothyroidism in pregnancy, hyperthyroidism in pregnancy, postpartum thyroiditis, or in short, PPT. Other than that, I will also cover for acquired hyperthyroidism in children. And at the end of my presentation, I will also discuss about drug treatment for thyroid disorders in elderly. So the first one is hypothyroidism. So basically, hypothyroidism in pregnancy can be defined as presence of low low serum TSH during the pregnancy, which is below the lower limit of the pregnancy specific reference range. The drug that need to be given is levothyroxine, or in short LT4, where I believe the mechanism of action of this drug has been discussed by the previous presenter in the case of hypothyroidism. So for the dosing, we need to note that for pregnant women who are already treated with levothyroxine before the conception, recommended to have the LT4 dosage to be increased by 30% upon the conception, which is within 4 to 6 weeks of gestation. And the dosage can be gradually increased through mid-gestation, which is between 16 to 20 weeks, and later during the third trimester until the delivery. The dosage that require is plateau. And levothyroxine dosage can be readjusted to pre-pregnancy level after the delivery happened. And for pharmacokinetics, I think through my presentation, I will just keep the pharmacokinetic parts as well as the mechanism of action, the adverse effects of the drug, as I believe it has been covered very well by the previous presenters. And maybe I will just discuss it briefly where it needed. And the adverse effect that related is the risk of over-treatment. That later will be result in TSH suppression. And moving on to the next special situation, which is the hyperthyroidism in pregnancy. So this condition will be subdivided furthermore into the gestational transient thyrotoxicosis, Graves' disease, or in the time of hyperthyroidism occurs prior to conception or early in pregnancy, or even during the pregnancy, as well as thyrotoxicosis in postpartum period. So in the case of GTT, where there is hyperemesis gravidarum, the management will be focused mainly in supportive such as rehydration or even hospitalization if needed. So the mother can also be prescribed with beta blocker. Beta blocker is needed if the symptom is very prominent. So in this case, it is important to note that the anti-thyroid drug or ATD is not recommended. This is because there is possibility of increased risk of birth defect with ATD used in early pregnancy. So in Graves' disease, specifically prior to conception or early in pregnancy, patients who are well controlled on carbimazole and plan to conceive should switch to propylthiouracil (PTU) before trying to conceive. And whereas during the pregnancy, PTU is recommended throughout the first trimester. And for the dosage, when CMZ replaced to PTU, the ratio that should be used is 1 to 10, where carbimazole is 1 and propylthiouracil is 10. For example, PTU per day is for 200 milligram PTU per day is needed to replace the 20 milligram carbimazole. This is because the half-life of the propylthiouracil is considerably shorter, so it should be used twice daily. So because all of the ATDs has the ability to cross the placenta, it may cause fetal thyroid function to be affected. And this later will be cause the hypothyroidism and eventually goiter. So adverse effects of using ATDs during the pregnancy is the teratogenicity potential. So with the use of the propylthiouracil, there is liver failure. But the risk of liver failure is much lower than the risk of birth defects. So in the case of thyrotoxicosis in breastfeeding women, both of the CMZ and PTU can be administered. And next special situation is postpartum thyroiditis. For women in thyrotoxicosis phase or postpartum thyroiditis who are symptomatic should be treated with beta blockers. And during this phase, anti-thyroid drug recommended. So the example of beta blockers that is safe for lactating mother are propranolol and also the metoprolol. And these should be given at lowest possible dose. We just give these beta blockers to alleviate the symptoms. So other than that, women in hypothyroid phase of PPT and who are symptomatic should be treated with levothyroxine. And the same goes with women who choose to get pregnant again while they are in hypothyroid phase of postpartum thyroiditis. Or women who are breastfeeding, it is also recommended to take the levothyroxine or LT4. So next special situation is acquired hypothyroidism in children and adolescents. So the drug treatment for hypothyroidism secondary to Hashimoto's thyroiditis, non-goitrous euthyroid Hashimoto's thyroid, and euthyroid Hashimoto thyroiditis with goiter. All these conditions we treat with the same drug, which is levothyroxine LT4. So the difference is only can be seen in the dosage. So we need to note that the rate of clearance of levothyroxine LT4 is higher in children than adults. So as a result, the daily on a weight basis is higher in children. And for the next is hyperthyroidism in children and adolescents. So the first line initial treatment is ATD, which is carbimazole or its active metabolite metimazole. So in this case, the anti-thyroid drug PTU should be avoided because it may increase the risk of idiosyncratic liver failure. So the adverse effect that usually happen with this drug is dose related, have minor reaction such as rash, urticaria, hair loss, and patient might also get severe reaction such as Stevens-Johnson syndrome, neutropenia, as well as thrombocytopenia. And lastly, for thyroid disorders in elderly, in patients with hypothyroidism, the drug treatment is also LT4, where the regimen should be started with small dose. And the adverse effect that might be seen is thyroid hormone excess that will be resulting in atrial fibrillation as well as osteoporotic fractures. And I think this is the last special situation. That's all for my part. I will pass the presentation to the next presenter. Thank you.
All right, a very good morning to the doctor and also to my partner Afif. Okay, so today we and Afif are going to be presenting about drug-induced thyroid disorders. Okay, so we have classified them. There are 6 types of drugs, right, that may induce thyroid disorders, and these are the drugs that whatever they cause, such as maybe hypothyroidism later on. You're just going to be repeating you're just going to stop the drug administration, all right, depending on the drug and the condition. And later on, we're just going to have the same treatment as those of the treatments listed above just now that's presented by the rest of the group members just now. So let me start. So first we have amiodarone. Okay, so amiodarone, it may cause amiodarone-induced thyrotoxicosis, also amiodarone-induced hypothyroidism, right? So as just now, my fellow teammate has presented about hypothyroidism. So what we have to do, just like I said just now, we have to stop the administration of amiodarone, all right, or reduce the administration, and then we have to treat accordingly to what my teammate has presented just now. All right, next we have interferon alpha, IFNA. All right, IFNA alpha. So this drug may cause a few types of diseases, such as Graves' disease. All right, so it's treated with anti-thyroid drugs. And then we have the thyrotoxic phase of thyroiditis is managed with beta blockers, as presented just now, if it's only symptomatic. And the hypothyroid phase, if symptomatic, is treated with levothyroxine. So all those drugs that I've listed just now is already explained by the previous presenters. So, however, for interferon alpha, the discontinuation of this drug is not necessary. It depends on the situation, right? So the third one and the last one I'm going to be presenting is interleukin-2. So patients with metastatic cancer and leukemia who are treated with interleukin-2 have been reported, all right, there's some statistical data that reported to have developed thyroid dysfunction, mainly from thyroiditis, hypothyroidism, and hyperthyroidism. All right, now I'll pass it to Afif to present the next 3 drugs.
Okay, David, thank you. So the next 3 drugs that can induce the thyroid disorder. So the first one is tyrosine kinase inhibitors, also known as TKI. So the TKI such as sunitinib, sorafenib, and nilotinib are used to treat malignancies such as metastatic renal cell carcinoma, hepatoma, thyroid cancer, and also GIST. But sunitinib and sorafenib can induce hypothyroidism, where the mechanism of thyroid dysfunction includes primary hypothyroidism and also disruptive thyroiditis. The next drug that can induce thyroid disorder is lithium, where the lithium will inhibit the thyroid hormone release, and it may result in the development of goiter and also hypothyroidism. And last but not least is immune checkpoint inhibitors, where immune checkpoint inhibitors has been associated with endocrinopathies such as disruptive thyroiditis, adrenal insufficiency, and hypophysitis, where it's leading to secondary hypothyroidism and other associated hormonal deficiencies. Yeah, I think that's all from us regarding the drug that can induce thyroid disorder. Thank you.
Assalamualaikum warahmatullahi wabarakatuh. My name is Rashida Bin and I'm going to present about the drug treatment option for thyroid disorder, which is specifically ophthalmopathy or known as GO. Okay, basically, I refer to the CPG book for the thyroid disorder. So first, so GO or Graves ophthalmopathy are divided into severity, which is mild, moderate to severe and active. Life-threatening active, which is the example is thyroid optic neuropathy, moderate to severe and inactive, and also radioactive iodine therapy and GO. So for the mild one, based on the book CPG book, the drug treatment are sodium cyanide. Okay, and the dosage regimen is 100 mcg BD for 6 months BD by daily, 2 times a day, and there is no significant adverse effect. And then for the moderate to severe and active, with 2 line treatment, which is the first line is glucocorticoids, specifically methylprednisolone. Okay. Dosage regimen is intermediate dose of IV intravenous methylprednisolone at 0.5 gram weekly for 6 weeks, followed by 0.25 gram weekly for 6 weeks. Cumulative dose of 4.5 gram in most cases of moderate to severe GO. GO. And then high doses with an accumulative dose of 7.5 gram methylprednisolone given 0.75 gram weekly for 6 weeks, followed by 0.5 gram weekly for 6 weeks, can be considered in worst case within the moderate to severe spectrum. So for the pharmacokinetics for this first line treatment, it is stated that the intravenous glucocorticoids have more action than the oral glucocorticoids. And then cumulative dose of IV methylprednisolone should not be exceed 8 grams. And then for the adverse effects for the glucocorticoid methylprednisolone, there are contraindications for systemic GC. Okay, yes, viral hepatitis, for example, significant hepatic dysfunction, severe cardiovascular morbidity, uncontrolled hypertension, psychiatric disorder. And then we go to second line treatment. It is a combination of cyclosporine and glucocorticoids. Okay, so for the dosage regimen, it's cumulative dose of 20 grams per orbit, fractionally in 10 daily dose given over 2 weeks period. And then also there are no significant pharmacokinetic adverse effects. So now the next position is for the type 2 disorder optic neuropathy or DOE. We also give the glucocorticoids or methylprednisolone. Okay, at very high doses of intravenous GC, 500 to 1,000 milligrams of methylprednisolone for 3 consecutive days or on alternative days during the first week, and then the doses should be repeated in the second week. If the response is absent of both, urgent orbital dissolution should be done. And then for the next audition, next severity, moderate and severe. To severe and active ratio, there are no stated specific drug treatment, but it's just that rehabilitative surgery should be done after the disease has been inactive for 6 months. Different degrees and type of surgical intervention may be needed depending on the amount of disfigurement and dysfunction that perceived in the post-inflammatory phase. Means that the surgery will depend on the needed of the disease. So there is a few options for rehabilitative surgery. The A is decompression surgery to reduce intraocular pressure, avoiding the bony orbit with different degrees of extension of medial lateral orbital wall or removal of the orbital flaw. And then the second option is strabismus or squint surgery, which is to restore fusion in primary position, avoiding diplopia in downward changes and intercorrect residual incompetence. Then there are the other two, eyelid surgery and also orbital surgery. And the last but not least is radioactive iodine therapy and GO, which is basically these are indicated for those who patients who undergo who patients who have GO, they undergo iodine therapy, so they will need it to prescribe this prednisolone, um, which is by orally prophylaxis of 0.5 until 0.5 milligram per kilogram per day for a total of 3 months is recommended in patients with mild to moderate GO who are undergo radioiodine therapy. And then lower dose of oral prednisolone prophylaxis or of 0.2 to 0.3 milligram per kilogram per day can be used in patients with moderate GO or have risk factor for the GO. Okay, and here is the table, the summary table for the management of Graves' ophthalmopathy GO. So that's all for me. Thank you.